Okay. Hello, everyone. This chapter is going to be focused on chapter 41, diabetes mellitus. With this chapter, we're going to focus on the two different types of diabetes, type 1, type 2, as well as gestational and some others. We will also go into detail with the etiologies, risk factors, the pathogenesis, some signs and symptoms, definitely complications, as well as treatment and management of these conditions. Okay, so before we get started, we're actually going to focus on the anatomy and physiology. Okay, there we go. Sorry, the slides were taking a long time to turn. Okay, so the regulation of glucose metabolism, this should be somewhat familiar to you from anatomy and physiology. So we're just going to go over the regular hormonal regulation that happens within the pancreas. So insulin is synthesized in the pancreas by the beta cells of the islets of Langerhans, if you remember that from anatomy. The beta cells do produce what is called proinsulin. We also have alpha cells that produce glucagon, and then we have our delta cells that produce somatostatin. We also have F cells that produce pancreatic polypeptides, which are also very important for digestion. Now, with glucose, or I should say hormonal regulation, the ingestion of nutrients stimulates the release of glucose-dependent insulin iatrogenic polypeptide, GIP, and glucagon-like peptide 1, GLP-1, from the cells in the gut. What this does, this stimulates the production of insulin and it inhibits glucagon. So if you remember from anatomy and physiology, insulin and glucagon, they actually are antagonistic to each other. So insulin will stimulate the diffusion of glucose into adipose and muscle cells, okay, or muscle tissue. And then glucose oxidizes in the cells, which are called glycolysis, if you also remember that. And that's used primarily for glycogenolysis. So, long story short, what happens is we know that glucose can actually be stored for further use in the future. In the need that we are in need of glucose, we can actually break it down into what we call glycolysis or glycogenolysis. Okay, so in fasting state, glucose is produced by glycogenolysis or gluconeogenesis, while insulin secretion falls to the basal level. So during fasting, the body recognizes that it does not have the adequate amount of glucose that it needs. Keep in mind, glucose is the energy fuel for the cells, so we do need an adequate amount of glucose circulating in the body in order to have cellular processes happen. However, we don't want to go obviously over that level. But in the situation of fasting, glucose will be produced by glycogenolysis, where it can actually be split by glycogen, or gluconeogenesis, where it's actually made from combination of what's happening with the liver and fat cells. Glucagon is responsible for most glucose production in fasting. Okay, so that part we should know. And then other counter-regulatory hormones such as corticosteroids, growth hormone, catecholamines, they do augment also the glucose production. So we do have a combination of things that work together. Now, during exercise, initially, glucose levels drop and glucagon and catecholamine levels rise. And what they do is increase the production of free fatty acids and they stimulate glycogenolysis. Okay, so this is going to be the splitting. There will be a rise in glucose to meet the energy demands. And so this is something that is normally supposed to occur because of the amount of energy or metabolic activity that is happening in the body. So muscle tissue increases metabolism of glucose as exercise continues, increasing insulin sensitivity and maintaining normal blood glucose levels in the presence of lower insulin levels. Now, stress. Can stress affect this? Definitely. So we discussed maybe a little bit about this portion in chapter 2 when we talked about stress and how, there's different body systems that will regulate certain hormone levels and stimulate things. So the production of stress hormones, corticosteroids and catecholamines do increase the production of glucose in the liver and glucagon in the pancreas. And it decreases the utilization of glucose. Okay, so it will pretty much act as a sense where the body will kind of store it or, try to prevent any further, issues. So catecholamines increases the production of free fatty acids and it inhibits glucose uptake in the periphery. All of these events can lead to hyperglycemia. So now we're going to go to discussing the different disorders. So for type 1, we'll discuss type 1 diabetes, type 2. We will discuss some other specific types of diabetes mellitus, and then gestational diabetes, which pretty much mimics type 2. So for type 1, and I'm going to tell you exactly what to kind of focus on here and what I'm stressing. It is definitely important to know this first bullet point here. Type 1 is characterized by destruction of beta cells of the pancreas. That is definitely the hallmark pathogenesis here, etiology, because what happens is that these beta cells are just actually destroyed, okay, with type 1. This particular type is usually diagnosed between ages 5 to 20 years of age. Sometimes people used to call this juvenile type of diabetes because usually most diagnoses do happen in younger years. The etiology may be immune mediated or idiopathic without any autoimmune markers or HLA association. So, but in most cases, it is really more so idiopathic. Sometimes people do also put this under possible congenital type situation, but definitely more of a juvenile type of situation where it's actually diagnosed around that age. And it does have an idiopathic cause to it. So this results basically in absolute insulin deficiency. So if you have destruction of the beta cells, the insulin is just completely destroyed, or I should say deficient. The overproduction of glucagon stimulates glycogenolysis and gluconeogenesis. So therefore, it will now kick out as much glucose as the body can kick out. When this occurs, this will lead to the next bullet point here, which is glucose levels will rise. Once glucose levels rise, they're rising to an amount that is a little too much, and so this can lead to certain symptoms that these patients will have, which leads to what we call polyuria, polydipsia, and polyphagia. So polyuria is increase in urination, polydipsia is increase in thirst, and polyphagia is increase in um, hunger. Okay, so this happens because the glucose levels are rising and the body is actually requiring more nutrients to actually metabolize, everything that's going on. So we also have free fatty acids that are transformed into ketones, leading these patients into ketoacidosis. The issue here is that as the glucose levels rise, free fatty acids will actually start to elevate as well as kind of like, I don't want to say exactly a byproduct, but just kind of part of the situation. And then the problem here is that once the free fatty acids actually continue to, just kind of linger around in the bloodstream, they will actually turn into ketones. Ketone bodies are basically waste products the body doesn't need. It's supposed to kind of push it out through various processes. However, if it stays in the bloodstream, this can lead a person into ketoacidosis, in which the blood can become acidic. So here's a visual of that. Okay, and so not that I need you to memorize each and every item here, but just to give you a visual as to which organs are involved, understanding that free fatty acids are part of this, as well as the ketones that are being distributed. And so, as you can see, what's going in and out of the bloodstream and the various organs that are actually kicking those items into the bloodstream. Okay, so for diagnosis of diabetes, I think we would imagine that there's a few tests that can be performed. And not to get into a lot of detail with all the testing. However, there's a fasting blood glucose. There's also there have a 2-hour type of glucose testing. We can obviously test it through the bloodstream. We do look for just glucose levels, and then there's also where we look for um, HbA1c, which lets us know that, this has been going on and now attached to hemoglobin for quite some time. So we do have a variety of different testing, okay, that are here. Okay. Now, with type 2, let me just. Okay, sorry. So with type 2 diabetes, this is the most common type. Very important to know this. Non-Caucasian and elderly are disappropriately affected, so they are not affected as much. Um, or I should say that they are affected. I'm sorry, they are affected. Um, Common risk factor here definitely includes obesity, aging, sedentary lifestyle. Please, please, please make sure you know that. Um, because one of the major issues that occurs with this type of diabetes is that obesity. Obesity tends to be um, the major issue here as far as a major risk factor leading to this, and something that I don't want to say very hard, but sometimes challenging to get this under control and, the whole situation. So these patients are what we call insulin resistance and B cell dysfunction, which leads to the lack of insulin. So definitely a little different than type 1. So if you remember, type 1 was B cell destruction. This is actually B cell dysfunction. And then these patients are also insulin resistant, which means that the insulin receptors are not binding to the beta cells as they should, which is why it's a beta cell dysfunction. Okay. So there's not enough insulin that's being circulated to actually balance out the glucose levels that are in the bloodstream. So again, here's another image of organs that are involved and glucose levels that can be kicking into this bloodstream and how it happens. So just to have an understanding with that. And so with type 2, these patients can also have polyuria, polydipsia, and polyphagia, just like type 1. The only difference here is that this can be a little more subtle. It's not as apparent with type 1. So, they say with type 1, the 3 polys are definitely present. Here, it may be present, like, let's say, sort of in the beginning stages of the condition, but, it's not as much as you would see with type 1. Ketoacidosis is uncommon here. However, these patients can lead to what is called hyperglycemic, hyperosmolar, non-ketotic coma, which means that this can develop due to severe dehydration. So again, the more glucose levels that's circulating in the blood, it'll kind of increase a metabolic activity in a sense where the body will need more nutrients, more water. If they do lead to a severe dehydration, this could possibly happen because of the hyperglycemia. Okay. So this slide covers different blood panels. Okay. So for test purposes, for the patho course on ground, we're going to focus on this more so for in-class activities. So for test purposes, we don't have to worry about these levels here. So we'll incorporate that. But just so you can have an idea, you can just take a glance at it as to what levels, what it will look like if a person is in ketoacidosis versus a non-ketotic situation. Okay, so there are other types. Sorry. There are other types of diabetes. We do have genetic defects of beta cells. This is a mature onset of diabetes of the young. Um, so this is more of the genetic type disorder. We also have genetic defects that can happen in insulin action. There can also be diseases of exocrine pancreas, endocrine pathogeneses, and then drug chemical infection induced diabetes. So there's other ways that people can become diabetic. So just as an example, if you remember from chapter, what was it, 37 with chronic pancreatitis, those patients can actually lead to, a type of diabetes because of that. So it just depends on the cause. However, I think clinically we see type 2 way more than the others. So, we definitely want to focus on that as well as type 1. Type 2 and type 1, definitely you see a lot. Now, gestational diabetes is defined as diabetes that develops when the mom is pregnant. So it's a disorder of glucose intolerance of variable severity with the onset during pregnancy. So the mom, develops this. This closely resembles type 2. So as far as, the way it's designed, I would know that most likely precipitated by the presence of placental hormones. And the management is definitely through dietary counseling, exercise, and blood glucose ketone monitoring. Because again, with type 2, as we said earlier, obesity plays a very, very major role in this. So any type of nutritional or dietary changes is important for not only type 2, but definitely for gestational. So here's a table, that shows us the diagnosis and what it looks like as far as like the testing and the levels. Again, we can save this more for in-class activity purposes. Okay. Now, a couple of things that is very important, and I think we all know this. If you go to the doctor and get your annual checkup, we are always looking at to see if a person is quote unquote pre-diabetic or leading into pre-diabetes. It is important to identify pre-diabetes because when a patient is pre-diabetic, they can be at risk for not only just the full-blown type 2 diabetes, but also the complications that go along with that. Okay. So, impaired glucose tolerance and impaired fasting glucose tolerance is what is noted here for pre-diabetic patients. Intermediate stages between normal glucose metabolism and diabetes. The present risk factors for the development of diabetes and the onset of cardiovascular disease, which is what we're going to get into in a lot of detail. Okay. So here are the screenings. Again, we'll save a lot of this diagnostic testing type things for any in-class work, but it's here so you can take a look at that at your leisure. Now, screening for diabetes, all adults over the age 45 at least every 3 years. Okay, individuals with risk factors should be screened earlier or more frequently. Now, we do have some clinical manifestations and complications that could happen. So if a person is, let's say, pre-diabetic or the glucose levels elevate in whatever situation, if they are in what is considered an acute hyperglycemia, this is commonly caused by alterations in nutrition and activity, inadequate use of anti-diabetic medications. So the symptoms will be here: polyuria, polydipsia, polyphagia. They can also be nauseous, fatigue, and have blurred vision. And these patients can be more prone to infections. Now, with chronic hyperglycemia, this will lead to more chronic conditions because with chronic, this is long-standing over time. Things start to, just increase or get worse. So this may lead to systemic changes over time and increase the risk factors of other diseases, such as metabolic syndrome, hypertension, cardiovascular disease, and stroke. And complications are categorized as vascular and neuropathic. We're going to go into this in a lot of detail because what I want you to understand is that when a person is diabetic, this is a metabolic syndrome, which means that it, can alter many things in the body. What also happens here is that when it becomes complicated or chronic, or just long-standing situation, this can affect the cardiovascular system as well as affecting the neuro system. So those two things are very important to know because now this actually predisposes these patients into a whole list of different, conditions that, are just coming from this. So it's kind of like how when we discuss hypertension and organ damage, kind of the same thing here where these patients have this one condition. If it's not quite controlled, now they can lead to many, many types of in-organ damage. Okay. So we're going to start off with explaining vascular complications. So for vascular complications, we break it down into macrovascular and microvascular. So macrovascular is damage to large blood cells or blood vessels. This can lead to, oh gosh, I can't remember the abbreviation for this. CVD, chronic vascular disease. Sorry, it's late. I'm sorry. Chronic vascular disease and stroke. Okay, so this is what we're coronary vascular disease and stroke. So this is what we're concerned about with macrovascular. So with macrovascular, we want to think of larger vessels such as coronary arteries, such as you know, carotid arteries, things like that, that can possibly lead a person into a possible stroke. Microvascular, what falls under this category is retinopathies, so anything that's dealing with blood circulation to the eyes, and then nephropathies, which means this is blood circulation to the kidneys. And this happens due to abnormal thickening of the basement membrane in the capillaries, which unfortunately can lead to blindness and maybe renal failure. Okay. Please make sure you know this. Very, very important to focus on vascular complications because these are the things that can definitely develop if diabetes is chronic and it's not quite under control, and it can lead to these complications. So, macrovascular complications. Diabetes mellitus is independent risk factor for coronary artery disease. CAD risk factors such as dyslipidemia, hypertension, and impaired fibrinolysis are present in uncontrolled diabetes mellitus and can improve with blood glucose control. So I don't know if you remember, we had a discussion forum question. This was about, I think week 2 or week 3, with a patient that had some sort of coronary issues. I want to say he was having a mild heart attack or what have you. And in his history, he was diabetic, also had some vascular issues. The point here is that when patients are diabetic, they are automatically at risk for cardiovascular conditions that can lead to coronary artery disease. And when you tie in additional risk factors, such as a person not having a good diet and they have high lipids in the bloodstream, and this further complicates things, okay? So just keep that in mind. Now, with microvascular complications, hyperglycemia disrupts the platelet function and growth of the basement membrane, and the thickening of the basement membrane may improve with glycemic control levels. So with the thickening of that basement membrane, this unfortunately can disrupt what's happening with blood flow. The risk factors here of microvascular complications definitely include hypertension and smoking. Now, neuropathic complications with diabetic neuropathy, this can disturb not only just thinking about sensory type disturbances when people have neuro issues, but we also want to think of things, everything actually, because we know that the nervous system innervates every single system in the body, every organ, everything. So, we can't really do much of anything without our nervous system. However, it breaks it down into the autonomic dysfunction that can occur, such as GI disturbances, bladder dysfunction, tachycardia, postural hypotension, and possibly sexual dysfunction. Um, Sensory disturbances can include carpal tunnel syndrome, paresthesias, dysthesias in the extremities. And so I would know this as well because they can have neuropathies. So with neuropathic complications, excessive glucose is thought to interfere with what is called the myoinositol in neurons and reduce the myoinositol in peripheral nerves, which means that we're not going to have proper nerve impulses at this point. Glycemic control may prevent or improve these symptoms. Okay, so again, it all goes back to regulating the glucose levels. So complications in pregnancy. For type 1 diabetes, there's a high risk in perinatal infant mortality and congenital abnormalities, okay, for patients that are type 1 diabetic. They are monitored very closely, okay, when they're pregnant. Glycemic control before conception and during pregnancy may reduce these risks. Now, when it comes to treatment and education, I'm going to go through this a little quickly because I want you to know definitely the things that what we call these modifiable type of risk factors, things that we can address. And then it gets also in more detail with the actual medications. I As you guys know, for the patho course online, I don't on ground I really don't give as many treatment questions, and so you get that more so in your nursing program. But I just want to at least just go over and highlight some of these options. So nutrition for sure, because what did we say one of the major issues are with diabetes? Obesity. Okay, so we want to make sure that a person is changing their diet, decreasing their caloric intake, and all that good stuff. Okay, so here's a chart that actually goes over, some goals, interventions, just kind of a little protocol here. I'm not sure if this is up to date with your information that you will receive in nursing, but this is just what's in our patho book. Okay. Protein is used in the repair and growth of tissue. Okay, so 4 calories per gram. Okay, so this stimulates the secretion of insulin without increasing blood glucose levels. So we want to make sure that we have the recommended amount of protein. Okay, excessive protein may cause neuropathy. So this is something that we also want to kind of control in this situation, is the glucose and also the protein levels. Fat, we definitely want to control. So for a number of conditions, not just diabetes. So anyway, this talks about the types of fat we're discussing here is saturated, monounsaturated, and unsaturated. Just overall. So 9 calories per gram. The dietary saturated fat and cholesterol may lead to hypercholesterolemia, which we know is definitely going to put these patients at risk or increase their risk factors for CAD. And this also complicates things with the diabetes as well. Excuse me. Carbohydrates are characterized as saccharides and polysaccharides. Okay, so when we talk about polysaccharides, we know we're discussing our complex carbs, whereas the monosaccharides are simple sugars. This, as we know, definitely need to be monitored. because our polysaccharides, since we know from physiology, do break down into monosaccharides. And this can also alter, obviously, these patients' glucose levels. So 4 calories per gram, carbohydrate intake may be monitored by carb counting, and the glycemic load and index may also be of a benefit. Alcohol. Yes, alcohol. Okay, so alcohol, 7 calories per gram. The issue here is that the alcohol should be avoided because it can offset the glycemic level. Okay. They have here limited 1 drink per day for women, 2 for men to be avoided with poor glycemic control. And they give you the conditions here and, what it can, be associated with. When you get into your future courses, I'm quite sure you're going to need to know this information detailed, like, okay, well, women can have, and it breaks it down sometimes into ounces and all that, and what type of alcohol. But it definitely should be avoided in this condition. Okay. Obesity and eating disorders, as we said earlier, is definitely the strongest risk factor for diabetes mellitus, which is something that I would know for sure, as I said earlier. So this goes over the obesity, the body mass index, what we're looking for, recommendations, obviously, nutritional program, as well as diet, exercise. Bulimia and anorexia, they actually may be more common in type 1. Okay, so careful assessment is needed for that. Exercise, we already know, in conjunction with a great diet, will help, okay, for all types of diabetes, and it actually lowers as well as the cardiovascular risk factors. Okay, so that's important to know. And then now we get into some of the medications that are used. So there are oral anti-diabetic agents, and you have here listed what they're used for. And there's some more, and here's some more here. And as far as like what they're, the onset and duration, and what the purpose of these medications are for. Again, as you guys know, I don't get into medications and treatment questions for the course. And we have some more listed here. And then obviously what insulin is going to do, that's obviously the big one, especially for patients that have type 1, type 2 diabetes. There's different types. There's some fast acting, short acting, intermediate, long acting, and there's various ways that it can be administered as well. And for hypoglycemia, which we haven't talked about at all, but sometimes people can have low blood glucose levels. Okay. And so most common complication of insulin therapy, because sometimes it can drop it too low. Okay. And so the symptoms here, they can have pallor, tremor, diaphoresis, palpitations, and anxiety. Education on symptoms and management of hypoglycemia should be addressed definitely with all diabetic patients. And it's more so just kind of controlling the meds and the dosage. Um, we do also have some other forms of how insulin therapy can be utilized, as I said earlier, so we can just take a look at that. Stress management for sure, I would say, for all conditions, but especially for diabetes mellitus, it's important that they control this, because stress plays a major role in this as well. And then assessment of efficacy is when we have the glycosylated hemoglobin is used to determine the long-term glycemic control and to evaluate therapeutic goals. So I would know this. This is kind of the major test that is used, especially when we're trying to assess a person that is pre-diabetic or, diabetic. So looking at the blood work of what we call HbA1c. So it's a glycosylated hemoglobin, and it lets us know that there's long-term glycemic issues that's occurring if it's elevated. So that's all listed there. And then again, just more education for the patient, and just making sure the patient understands their goals for therapy. We do have, sorry. pediatric situations. So for pediatric situations, not much different than adults, but just making sure that we really, really monitor and focus on, the diet and screening and counseling and treatment and things of that nature. We also have geriatric considerations, again, not much different than the other slides that we went over. But just knowing what happens during acute complications, chronic, which again is the same pretty much as the type 2 diabetes. And treatments are listed here. And that is it. So hopefully you enjoyed chapter 41. And I will talk to you guys another time.